So, good morning, one and all. I bring greetings from the Center for Health and Development, Jain University, and the Madras Diabetes Research Foundation. Good morning, Namaste, Ram Ram, Vanakkam, Salam Alaikum. So, I'll be talking to you on championing mental health and social responsibility. Today, mental health is at the crossroads, and this is a call to unite. Each of us can do our bit to make this world a better place. Here is the photo of a lady. She is distressed, in delusion, half naked, found on the streets, is not aware of her name. Well, this is the story of a lot of people among India's urban poor. We come across them every day, but to what extent do we play a role in influencing their lives? Mental health is nothing but like an iceberg today, and the thing that is submerged is huge. This was a nice saying. When I use the word body, I mean much more than the physical machine. Not only do you physically live the circumstance around you, but also those only think of in your mind. Your physically felt body is in fact a part of the gigantic system here. It's a prejudice that we don't take mental health seriously. Suppose a person has fever, or suppose a person is uncomfortable, he would rush to the doctor. But when the mind shifts in its frequency, we'll say chalta hai yaar or dekhenge. So that's the attitude, and I'm sure there's nobody here who can say that they are mentally healthy. Can anybody say that? The WHO health gap suggested a lifetime prevalence of around 12 to 48% of mental disorders that can take place in an individual. Inequality in resource distribution, frustrations in life, and our opportunistic nature of approaching things today is one of the main factors for mental health. And you have the changing dynamics today with overcrowding in the urban population, poverty, newer forms of poverty where people lack for love, people are more in need for compassion, people lack attention. That is the new forms of poverty we face today in the health domain. Of course, our economic segment is different, and the poverty we face here is different. Another thing is scarcity of resources, which is either real or assumed. Among the youngsters, it's not enough to have a mobile now. We want iPhone, we want smartphone, we want more and more. And if we don't get that, we are disturbed. So that's what I mean with real and assumed in this fast-paced world. The access to drugs in the urban population creates a carnival which leads to this mental health burdens. Time spent on the internet and the time lost, I will get back to this on a later slide. Then the words like suicide, violence, crime, depression are not just words. These are very heavy situations which, if we place ourselves, we will then begin to realize. Just imagine putting yourself in the shoes of a schizophrenia patient. What goes on in his mind? How does he really feel? And how do we look at society that way? Just view it from a prism of a person who would like to commit suicide. From the eyes of an urban poor. View it from the prism of someone who has nothing to offer in this world. What good does it do to treat people illness only to get them back to the condition that made them sick? You have fast foods, you have rates of violence and crime, liquor store density, children living in poverty, obesity. These are all the influences that happen outside the doctor's office. And here you have slum housing, high school graduation rates, air pollution, unemployment, smoking. All this happens in the area where we live. It happens next to us. And this directly influences our state of mind. You may have learned the technical details of the human body. You might have been one of the best practicing doctors anywhere in the country or internationally. But all these does not matter if you cannot connect with your patients. This brings us to nurture the doctor-patient relationship. How many of us can really spend time today? We want to see more patients because it's sexy, it's cool to tell I have around 100, 200 patients every day. But how much time do you spend with each person? It's negligible. And it's also time tested and proven that 50 to 70% of a patient's illness goes just by sweet talks and by comforting. And how many of us can really do that today? This gives a look of the various determinants that influence health, and the startling fact is here. 50 to 60% is just socio-economic environment. This was a study done by Evans on why some people are healthy and why others are not. We need to create an environment which can train future doctors, psychiatrists, psychologists to identify the factors that cause socio-economic burden on the mind and on the health status as such. Unless we do that, unless we reform our education system, this is just going to increase and we are going to be in that iceberg which you just saw before. Using this disability adjusted life years DALI, we need to shift the focus from not how they die, but now to how they live. With the advent of senior citizens' homes coming in, with the busy life which we all go through and we can't spend time with those who really need us, this is what we need to focus on, how they really live rather than how they die. For example, DALI is lost to Alzheimer's. You have life expectancy today, but at the cost of what? At the cost of the mind being outrun and being, like what you say, rusted out or something like that. Mental health as such is not fatal, but it's sufficient to cause disability that can be life-changing. The pressure to excel has superseded our necessity of survival. And most of us today live in self-denial. I don't know how many of you all will agree with this statement, but it's partially true. We all have mobile internet, we are connected on all the networking platforms. We would mind talking to a person through the internet, but if someone calls you for a cup of coffee, we don't have time. Of course, there's a radical transformation taking place with technology, with newer concepts that are coming in, society's perceptions and commercialization of existence. Please highlight this word, commercialization of existence. This is a clarion call for each of you to examine your inner self. Are you really happy with what you do? Do you get up every day and look forward to go to your work, or do you say, oh, I need to reach there by 8 or 9? This would only generate and manufacture depression and other psychiatric ailments, and it would create a hostile environment for all our mental health needs. How do we champion mental health and bring in social responsibility? This is the big question I'm putting to you today. Every patient, Harvey Cushing has said, comes to us with two questions. What can you do for him? What can you learn from him? These simple two questions would answer most of your mental health and social responsibility component of being in this healthcare profession. We can approach it through mental health education, where it just select pockets of some NGOs, civil society agents and institutions which just highlight some mental health needs on days of mental health relevance, but it needs to go on a bigger pace. We need to come out with more infographics, we need to come out with more memes, which can then trigger the mind to say, yes, this is an important component that defines society today. Approach to tackle the vulnerable population. When I mean the vulnerable population, it's the urban poor, the rural poor, those who are affected by different kinds of socio-economic problems. It silently and secretly influences the mind, frustration comes in and suicide approaches. Dangers, okay, I'll come to that. Engaging with the third sector. When I mean the third sector, it's not government, it's not corporate, it's the NGO sector. And target approaches through medical college hospitals. Can each of us working in medical college institutions or working in some psychology settings adopt certain wards or certain villages and then cater to them on a direct basis? Maybe once a month we can take a feedback from what they need, from what they have felt is an improvement by our coming. It's better to try and fail rather than never try at all. So think about this idea which I'm floating, and if you all are in a position of authority where you can use your discretion, please do that. You can get in touch with your local corporator or some religious institution, adopt that ward, adopt that village, and start talking to people. You'll discover a lot of things which you would never have learned attending a conference, attending or reading textbooks. I'll come to the social media dangers. I think I have a slide. Okay, safeguarding the urban poor, rag pickers, rickshaw pullers, truck drivers, slum dwellers, sex workers. These are people who will talk to you when you approach them for their work. But you need to build that bond, that belief and that responsibility which would help them to then accommodate you and adjust with you to listen to you. Creating community health centers, especially psychiatric specialty ones. I've spoken to the health minister about this. If we can bring in primary health centers which are also equipped with psychiatry, because most of the basic needs in psychiatry can be cured with primary health centers, and people in turn get lost by reaching tertiary hospitals. Connecting household to the facility. If there is a facility, we can definitely work to connect each household, make them aware of that particular facility and services that could be offered. Providing untied grants to mental health care. Right now we don't even have proper national policies, but providing untied grants for mental health care will go a long way to help those people who are in need. Here is a study which was done on medical students' attitudes towards providing care for the underserved. Are we training socially responsible physicians? And the study revealed that medical students in their final year are less favorably inclined to provide care for the underserved than comparing them to the medical students in the first year. This trend needs to change. And this study was done in 1993. We are in 2014, nothing has changed. Another study was done where medical students' attitude towards underserved patients, a longitudinal comparison of problem-based and traditional medicine curriculum, and it revealed that the commitment to caring the medically underserved was greater when the student entered medical school than when they graduated. And male and female students experience increasingly negative attitudes over the 4 years. This was another study where you see the attitude towards the homeless, and the question was, I believe that those who enter medicine or other disciplines want to help those in need, and only 37% agree. You have 16% who disagree, and neither agree or disagree 18%. And the health professionals' attitude towards the homeless, I believe that health professionals are too pressed for time to investigate psychosocial issues routinely. 46%. Health professionals have no time. And agree is 46%. Strongly agree is 10%. Becoming a doctor. If you can get this study, please read it. It's very exciting. A longitudinal study by Sherlock and Morris. Students are highly motivated to achieve economic and professional status, which I would say is important, but should not become a mandate or a priority. They adopt a rhetoric of altruism in order to not disclose their motives. What they mean by this is that they would associate with some setting which works with the poor for 1 or 2 days, take some photos, get associated, show that you've been part of it, and then sell it and build on it. Coming to dangers of social media, Twitter makes you think you're wise, Instagram makes you think you're a photographer, Facebook makes you think you have friends. It's not true. If you have 5,000 friends, please be sure it's not true. They just like things and keep you happy, and if you can find happiness in that, good. The wake up will be very tough.